part of this from the beginning. I have to take a moment to thank the team that makes this happen. Isn't this a lovely event? None of that is me, I can assure you. I have a wonderful team that works with me, including Abby Mock, who has worked on this from the very beginning. So I want to thank Abby, along with Jessica and Emily and a whole crew of people that have worked tirelessly to put this together, and Catherine has helped promote it. So the whole Translational Health Research Center team has worked on this event, and the new swag bags were all Emily, so thanks for that, I appreciate it. They really do a great job, and I would be remiss if I didn't thank them. So to start our event off today, I'm very pleased to introduce someone that really probably doesn't need an introduction, but I have to say that he has been a fearless leader of about every research and academic program at Texas State over the last decade. Much of our success can be attributed to his leadership, and many of you know that he is a kind of leader that takes personal attention in faculty and staff and students to help us be successful, and for that I'm incredibly grateful. And for me personally, I was, as usual, noticing maybe a place where Texas State would be able to change or to improve. And at that very moment, it was my great fortune that he and President Trouth were also noticing that Texas State had health research in every college. And so for me, it was a matter of thinking about ways to connect our research mission across the university at a place that's uphill in both directions and makes it difficult for us to talk to each other sometimes. So the Health Scholar Showcase was born out of that idea, out of something that was recognized by Dr. B and President Trouth at that time, and something that I got to help with by creating this event. So we could get to know each other and work together. And I can assure you, there have been many grants, many research projects, many publications that started with interactions at the Health Scholar Showcase, and we're very proud of that. So ladies and gentlemen, I'd like to introduce Dr. B.
To it in a way with the help of Melinda and the team, it feels good that you can actually do something, create something where you've got this many participants, which is typical of every year that we've done this, basically, where again, our outstanding faculty and others get to showcase their research in the broad areas of translational health research. Well, thanks Melinda and the entire team. I'm not going to name Abby and the others, so wherever you are, thank you very much. Good afternoon and welcome to everyone again to this edition of our Translational Health Research's Health Scholar Showcase. So I'm again honored to welcome you to not only this 7th one, but especially because the theme this year is about impactful, innovative, and inclusive health research that obviously, as you all have engaged in it, explores how solutions from Texas State University research and grants provide new potential to address some of our most critical health aspects and issues that we face today. And how timely and relevant all of this work truly is, especially concerning the role of impactful, innovative, and inclusive research in our 3 university goals, our 3 university initiatives, our 3 university bold promises made by President Damphus. So, and I don't want to confuse people again about strategic planning goals and big initiatives from the president. They're all going to be woven together and integrated into one thing soon. So just don't be alarmed that I'm announcing 3 new goals right now. You've heard these before. One of these goals includes efforts to quickly complete the necessary steps to earn a very high research university designation from the Carnegie Foundation. In other words, it's our run to R1. We have been working on that for nearly probably 12 years now. So this is really kind of the culmination, as Kelly has said often, about all of our efforts in the past to, in a way, to more quickly get us to an R1 designation. We want to seek our opportunities also for student success. So goal number 2, that is also obviously prevalent in our strategic planning goals. And then another one that's in the plan currently, but he's elevating it for a number of very good reasons, reasons, and that's expanding our programs in Round Rock. Basically expanding our presence, our programming, and our impact in Round Rock, Northern Travis County, and in Williamson County. So without question, impactful, innovative, and inclusive health research and the external funding that comes with them is going to be critical to help achieve each of these goals. So the run to R1, I think you know, is bolstered by our impactful and innovative health research that totaled, with other ideas, nearly $110 million in R&D expenditures this past year. That's a record for the university. And again, most of you, I think, know I'm a historian, so just one little historical tidbit in here. If you do go back to about the year 2005-ish, we were in single digits for both restricted research expenditures and total R&D. I mean, we were literally around 8 to 8.5 million in total R&D. So to go from that to 110 million at the close of fiscal year 22 is quite significant. It is impactful. It's a reason why Shreek decided to come here, because he could see the groundwork in part that has been laid upon which he and the rest of us can build. So, innovative research among our faculty affiliated with research labs and centers, such as the Translational Health Research Center, the Saphophorus Genetic Stock Center, which has been gaining external funds for more than 2 decades now, the Materials Application Research Center, Star Park, and other similar research programs throughout our academic colleges fuel this record surge in R&D. Not to be outdone by their STEM colleagues, right? Are all of those non-STEM things and folks. So what have the non-STEM health research grant and other programs been contributing? Well, enough dollars to earn Texas State a ranking of 46 among all universities in the Carnegie classification system for non-STEM restricted research expenditures, which is a pretty significant ranking given where we are in total as an R2. So I think that's outstanding. And that's without currently a single PhD program in the humanities. So imagine what it will be once we start layering in additional PhDs in the social sciences, but also in the humanities. So inclusive health research in STEM and non-STEM fields reflects our commitment and success with large interdisciplinary grants that bring together teams of our faculty and external partners who work together across traditional disciplinary boundaries on novel research. Several of these projects have recently earned significant grant funding due to the ability of our teams to propose multifaceted, cutting-edge research that requires input from experts in multiple fields of study. Our inclusive approach to health research also reflects the growing number of Texas State PIs who are women and people of color. I've got to say that one of the things that external folks who come and apply for and interview for chair positions, school director positions, deans, and VP and others typically point out that something that they've seen in the materials that they've received or find on the web is, for what they say, is a striking amount of interdisciplinary research done at, they say, a place like Texas State, which I'm taking that now as a compliment completely. I think because they don't know us. They don't actually know the level of research that we're doing. And even though we may not be structured like at Arizona State University after their restructuring a number of years ago, I think because basically for 2 decades now, we've been saying to faculty, as you come into your academic units, reach out, go outside of your department, your program, your department, and your school, and find partners elsewhere to do research. And obviously, that is a reason why we created the Translational Health Research Center. So in addition to these implications of impactful, innovative, and inclusive health research on our run to R1, there are also direct implications for student success. We focus increasingly on enhancing student success, and it wouldn't be complete without efforts to increase student research opportunities that can lead to greater career opportunities in the health and bio-life sciences industries, in particular given, again, the focus of this Health Scholars Showcase. For our graduate students, Texas State is dramatically increasing the number of doctoral students in our graduate programs, and we're working to ensure that our doctoral students have a clear path to timely graduation. These efforts will undoubtedly require planning to ensure that our graduate students can access high-quality research opportunities early and earlier in their degree programs. It will also take concerted efforts to ensure that we maximize support for our researchers and our postdocs in grant proposals whenever possible. So whether it's been Kelly making that plea or Shreek making that plea, the Provost is also making that plea to you all. Please, when you can, write in doc assistants and postdocs. We greatly appreciate all of your efforts to help us support them. That way I don't have to find as much funding and I can divert that to faculty positions, for example. So for undergraduates, our health research provides multiple ways to engage our students in research on topics that are relevant not only to the health of themselves and their family members, but to their careers and their career choices. Applied learning experiences during the research process can also help students gain valuable critical thinking skills, as well as teamwork skills that are in demand among many employers, and we expect that our new Idea Center and its activities to play an important role in expanding these opportunities for undergraduates. So remember, our QEP is focused around undergraduate research, and the Idea Center encapsulates those efforts. So this year, in today's annual Health Scholar Showcase, it's actually the second event this week sponsored by our center to celebrate the role of health research and grants at our university. The first event was yesterday when the center hosted a Student Health Scholar Showcase to increase awareness about marketable skills students can gain from participating in multi- and interdisciplinary health research while a student at Texas State. I hope I don't have to keep saying, to faculty the importance of identifying marketable skills. I do think in certain disciplines that's almost like a given, whereas in other disciplines it's not as readily something that faculty think about while we're creating our classes or even making our pathways for our students to follow through. But again, as easy as we can make it for them to help them realize by taking this course of study, you will gain these kinds of marketable skills that may land you a career maybe a little bit differently than what you were first thinking about. So again, I encourage everyone to think about as broadly as possible all of the different kinds of marketable skills you can advertise to our students. The keynote speaker for this event, Heather Hansen, CEO of San Antonio Biomed, shared examples. That's changed. So shared examples to help students know how to talk about their research experiences during job interviews. So you got someone who's basically in that sector who can give advice to our students about how to enhance what they present as they go out and look for jobs, look for careers, and look for placements. I'm also very much aware, again, that as we identify Texas and Central Texas employers who value these marketable skills most often associated with student health research experiences and curriculum, that we in my level and others have to do a greater job of basically marketing and advertising the broader reach of what they may find in Texas State students as potential employees. So again, just know that whenever I get a chance, and it's quite frequent actually, to talk about workforce development here at the Greater San Marcos Partnership and also with Austin Chamber and Austin Opportunity. Shreek is a little bit more involved than I am currently, as well as Ruth up in Round Rock, but we are constantly reminding at those events and with those audiences about what you all do as faculty and staff to help produce students who can meet the workforce demands of our entire Central Texas Innovation Corridor. Our goal to expand research and educational programs on the Round Rock campus also creates numerous new opportunities for impactful, innovative, inclusive health research in Williamson and a bunch now of adjacent counties, given the spread and proliferation of bio-life sciences firms in that greater kind of three and a half county area. There are literally hundreds of health and life science companies in that area within the Austin, Round Rock, San Marcos metropolitan statistical area. So an expanded presence in Round Rock will provide a broader foundation to pursue for us new research and grant partnerships with hospitals, medical laboratories, biopharmaceutical companies, healthcare organizations, and literally other related healthcare industries and their firms throughout the Central Texas area. We want to partner with the best and the brightest minds across healthcare, government, and higher ed, and our faculty, you all, can help improve the health of all people through our research with relevance to individuals, communities, and the workforce here in Central Texas. That's the mission of the center, the Translational Health Research Center, and its strategic focus on community health and economic resiliency research. It is making a tremendous impact, building capacity for research through all kinds of support programs, aiming to help faculty members pursue grants, other external funding opportunities for all of your research programs through stronger connections with businesses, nonprofits, and government agencies from San Antonio to Round Rock and beyond, especially now with new appropriated funding, definitely beyond this Central Texas area. The Translational Health Research Center allows us to accelerate the impact of research findings that help achieve goals for the state and for our citizens across a number of areas, such as reducing the impact of mental health issues on our communities, improving supply chain preparedness for threats to public health, and also creating novel approaches to personalized medicine for underrepresented populations and first responders. I'm extremely proud of this multidisciplinary research center, and I continue to be very impressed with all the very many examples of funded health research it has already earned and plans to pursue continuously under Melinda's leadership. Just this week, the THRC was awarded another grant worth $1 million to fund research on new mental health training programs in Travis County. So together, all of us and our partners are improving health by testing and applying research findings to address critical medical needs, and by educating and empowering communities to work together with us and with themselves on social and environmental factors that contribute to adverse health outcomes and obviously to find solutions for them. Our current goal is to become an R1 institution, to increase opportunities for student access and success, and expand our footprint in Round Rock, each provide new opportunities for novel health research and grant-funded interventions in conjunction with all of our various community partners. This event has, today it's doing, and will in the future, help showcase the wealth of activities and possibilities for our faculty to expand all of our health research through new grants and funding opportunities related to these goals, these three newer goals issued by Kelly, and then additional ones that you'll find in our plan. For me, again, it's extremely personally satisfying to see and hear about all of this, since this basically represents part of the vision that was behind the creation of this center. And it is true that in looking at tenure and promotion documents 8, 9, 10 years ago, seeing all of the health-related research that was done across the colleges, it did dawn on you after 3 years. It's like, everyone's doing health-related research in every college. We need to do something to bring people together to actually have even better, more better interdisciplinary, multidisciplinary activities and initiatives. So it's great to see it come to fruition, and now 7 years old, it's like, all right, what's in store for like the next 3, 10, or 15 years? Well, I think you all are going to be writing that story as our faculty who have been with us for a number of years and those faculty who have newly joined us continue to chart that path forward in terms of how we define translational health research at Texas State and how we define making meaningful impacts on health and communities in Central Texas and beyond. So thank you all very much. I'll now turn the program back over to Melinda, who will introduce our keynote speaker for today. Thank you.
Thank you very much. In addition to having a world-class Provost and Vice President for Academic Affairs, we also have a world-class speaker for you today. Dr. Jennifer Sharp Potter is Vice President for Research and Professor of Psychiatry and Behavioral Science at UT Health San Antonio. I was thrilled when she agreed to speak today because I believe that she has, we're kindred spirits in a way that we see the field of health research as being all-encompassing and creating opportunities across different disciplines that are really unique and impactful and fundable. So I am thrilled to have you. Dr. Potter joined UT Health San Antonio in 2008 after serving at Harvard Medical School in McLean Hospital in Bedford, Massachusetts. In 2012, she was promoted to Assistant Dean and then Vice Dean of Research in the Joe R. and Teresa Lozano Long School of Medicine at UT Health. She is an accomplished addiction scientist with
with a large portfolio of NIH research and public health funding, and leader of numerous grants and contracts across issues related to substance use and mental health. Dr. Potter is principal investigator with the National Institute on Drug Abuse Clinical Trials Network, and with funding from the Texas Health and Human Services Commission, she oversees a statewide public health initiative that is so awesome, and you should check it out. It's called Be Well Texas. So I am very thrilled to endorse that project, and I use it and look at it all the time. So you should too if you have a chance, and you're going to, I'm sure, enjoy hearing from Dr. Potter. Dr. Potter. After Dr. Potter speaks, she's going to answer questions, and our new Vice President for Research, Shreek, is going to join her as well to take questions from the audience. And so we'll pull questions, and you'll be able to ask her anything that you want to ask us since she finishes. So thank you so much.
Chair. Move around a lot, so I want to knock myself over and humiliate myself too quickly. Thank you so much, and it was wonderful to hear, I can't call you Dr. B, so I'm going to have to say Provost Bourgeois, did I get that right? Talk about the vision for the school we've just completed our university strategic plan, so these trigger words are very real and can often be exciting, but can also be stressful for faculty and staff as organizations grow. As I've come into leadership, I've learned holistically how much change is something that's good and exciting, but also as you grow an organization as rapidly as I hear that you all are doing, it's not without its struggles, but I hope that you also see the joy. We were chatting before, all of you were here about how much of an honor it is to be able to serve an academic mission. And it's complicated and it's tough, I think, particularly in Texas right now. And by the way, I appreciated your words around diversity and inclusion. It's complicated, but at the same time, I still wake up most of the time and want other people and learners to know how extraordinarily grateful and privileged I feel to work in an academic environment. So I hope that that joy in spite of change continues to persist here as it does at UT Health San Antonio. Like Texas State, we have gone through rather extraordinary growth over the past several years. Strangely, some of it perversely, I think, as a result of our global pandemic that we have all struggled through. And also because of a lot of really hard work. So I hope what I'm going to do today, I haven't presented this work in quite this frame, but when I heard the premise behind the meeting, I thought I'd get ready to go. So hopefully you don't think I'm completely bizarre at the end of this, and we'll see how it goes. I'm putting a timer on for myself. Okay, so when I took my position in the dean's office at the School of Medicine, it was 2012. I thought I'd moved from Harvard, I left my academic family, the people, I was a trailing spouse, the people that I thought I was going to be working with for the rest of my career were back at McLean. And I had a K, but I moved my K award at a very interesting time. It was about 12 months into it. And I thought, how am I going to do this? And I got to Texas in about 2008, and I thought I needed to diversify what I was going to do. One of my strengths is I'm very agile. I like to flex. I'll move quickly if I need to adapt to a situation. And I thought I was kind of moving away from being a faculty member and more into administration. And then, so the end result of that was I started to do more and more, and I got more and more promoted. And around 2016, 2017, I was perilously close to not being funded. And in a medical school environment, that is not a good thing. Because you have to understand where your funding is coming from. We will reduce salaries at our institution if you're not making your numbers. I had my administrative role, but I just felt really fried. I no longer believed in the joy of my science. I had about $250,000 worth of funding at the time, and I thought, well, I'm going to become an administrator because I liked it. It just wasn't. I just didn't have the energy I did. And then around 2018, the world shifted for me. And what I want to show you is that was also in some ways the beginning. We had a new dean of our medical school. We had a lot of new energy around the campus, a new president. And there was this really extraordinary moment in time related to substance use disorder, and all those things sort of converged and gave me a really unique opportunity. So what I want to do is talk a little bit about diversifying your funding portfolio, how you can do that, and how when you do these different things, you can maybe bring them together to something that's pretty extraordinary and more than what you started with. So just to level set, when I go through this, this is not a bragging event. This is about hard work and figuring out how to do something when you really are starting kind of from nothing. So I mentioned that 250 that I had, and I might be exaggerating slightly, in 2017, 2016, and I'm now a PI on close to $100 million worth of funding. But that's not all NIH funding. In fact, the NIH funding is less than the other funding that I have. And it's a really nice example as a social scientist, and it was so lovely to be here and walk through those posters and see all this beautiful social science work. I'm a computer scientist, anthropology, the libraries doing really interesting work, and it was really wonderful. I'm a social scientist. I'm a PhD with a theater degree at an academic health center that we're on track for $400 million a year, $400 million this year in sponsored programs activity. And notice I said sponsored programs, not research, because not all of the dollars that we get are sponsored programs. In fact, not all of the dollars are research. In fact, much of mine is sponsored program activity, serving the state, but not research. Okay, so I'm going to walk through this. And this is my North Star. So the first thing that I want to talk about is my program called Be Well Texas and how I leverage that. And this is an example of what we are continuing to do at UT Health as a way to diversify what we do, bring in more resources, create a broader seat at the table for more folks, and really understand how we can evolve as an academic health center to meet the needs of our communities. So if you look at those dots, and I'll get into this a little bit more, that's all of the places that Be Well Texas has a landing pad in Texas. So you can see what we've done with this is we've brought a program, including the research component of it, to scale throughout the entire state, and it represents over 211 programs. So again, I wanted to show you my funding, not just to disclose it, but to show you a little bit of how we did that. So we have our CTSA award, I'm the principal investigator on that, but more importantly, it's our clinical trials network that was mentioned. Our NCATS award, that's our CTSA award, and recently we have an R24 Peer Recovery Innovation Network, and then I also have some SBIRs. But most of this was built not through a traditional approach to applying for NIH research. You'll note there's no R01 on there. However, there are other major significant awards. And what we're doing is trying to continue to grow our NIH platform within my group using these funds. And so these, and I'm going to turn, for some reason I can't see that screen very well, so I'm just going to look here, pardon me. So if you look at these, this is a lot of contracts. All of these are applied theory-based approaches to applying evidence-based approaches, scaling them in Texas, and bringing them to bear on opioid use disorder and substance use disorder in Texas. It is these dollars, these sponsored program dollars, and I heard your Provost describe your mission of serving Texas. This is how we serve Texas, or one of the ways. All of these are the things that have been brought to bear to get to this funding portfolio here. So I want to talk a little bit about how we did that. The first thing is, if you're going to go out and work for this money, and as an organization I hear that in the values, if you're going to talk about funding, and we have to talk about funding, it's just a reality of how we live, you have to have your own North Star. And what is the North Star for your program? And that transcends any particular area. It's what is it that gets you up in the morning, that makes you decide to do the work that you do? My work is dedicated to the people, like the folks you see in this picture, and everything I do, they're my customers. And you probably already know, because you see parents holding pictures of children, what has happened to these children. And these children are no longer alive. They've been lost to the overdose epidemic in the United States. The one in the center, the woman, the mom holding with her son in the graduation gown, or his regalia, is a woman I met in San Antonio. I happened to meet her in 2018, and it was a big transformative moment when I met this woman at an overdose event that was going on in San Antonio. The other person there with a picture of his son, his son's name is Max, is a physician in Massachusetts who lost his son to the same disease. So that's the North Star of this. And what we do is we encourage all of our programs, our institutes, our centers, our faculty to really understand what it is that they're driving for and then how we're going to get there. The second message is, and this is from the Dean of our medical school, we dig holes, we don't plow fields. So scientists dig holes, they do not plow fields, because what we watch is when people get too spread out, we lose that North Star because we're splitting out too far. That's what collaborations and that's what teams are for. So the work that I do is my big, hairy, audacious goal is the moment a person in Texas is ready for help, that help is available. So that's a pretty audacious goal, but that's what we're working towards. And so that's how we came to have Be Well Texas. And so Be Well Texas, we would argue, is a very unique asset in Texas because it's publicly funded through Health and Human Services dollars to scale and spread the implementation of evidence-based practices for substance use disorder. We have a diverse and interprofessional team. We have all manner of folks from anthropologists to community-based organizations, people with lived experience of recovery, people who use drugs work for us, and all of these folks come together to work on this equitable access to high-quality, compassionate, evidence-based programs and services for people who use substances and those with a substance use disorder. I'm going to go through this quick because this isn't really the point of the conversation, but the programs are statewide and scaled for impact. So again, we are using these state dollars. If you don't work with Health and Human Services at all, one of the unique things about a state institution is that because we're state employees, we're also able to partner with the state with a different type of contracting process, and so they're able to sole source with us. And so we become the solution focus for the state. And one of the things that when we set out to do this was, I'm a scientist by training. Most of my career was built on developing evidence-based treatments for substance use disorder, both behavioral and pharmacological. So I'm a cognitive behavioral psychologist. What we agreed to do was we weren't just going to be a purveyor of these funds. We had to do this in a way that was informed by science and the training and background of the people here on my team. And we have about 94 folks that work with us specifically on Be Well Texas. So we have a provider network that's all over the state. You saw that on that map. That encompasses, I'm sorry, I did not realize the setup here. I hate when people say, I'm sorry, it's so small, but it really is small up there, isn't it? Our provider network scales a variety of programs and services related to people with a substance use disorder or people in recovery. A statewide network of recovery support services, largely built on a peer backbone. Hospital network, where we're doing the first in the state of Texas in-hospital induction of certain treatments for opioid use disorder, particularly buprenorphine. We use virtual health technology to link this and solve access issues throughout the state. We use telementoring, and then we also have a statewide recovery network for emerging adults. So that in a very much high level. And I'm going to show you how we link this all together. The impact of these programs at scale, you can see, has grown over time. It doesn't help to get $40 million about 4 months before a pandemic to try and hire a workforce to do this. And if you work at all in mental health, just like the rest of our industries, it's been a real struggle to identify our workforce to be able to serve the demands and needs that we have. But you can see the numbers of what we're working on are really starting to get at these fairly significant numbers of, particularly over time, such that we're more than doubling in 2023 the number of people that we touch. We touch them through their professional training for the workforce, as well as the direct-to-consumer services that we provide. So how do we do this? We do this through our statewide network, and you can see the metro areas there: Austin, Dallas, Fort Worth, Houston, and San Antonio. The challenge for us is how do we actually make sure? We don't go to all of these places, we partner with our community, because our community often has the best solutions. But we fund their work, we monitor it, we provide technical assistance. But again, when we started this work, we didn't think catchment area in all candor. We thought, what are we going to do that's going to be able to impact the most Texans possible and people who live in Texas? And that's why we do all of this work at scale. So we do that through a couple things. The first one I wanted to just very briefly touch on was the virtual clinic. So we now have what we think, as far as we know, is the only publicly funded substance use program in the state of Texas. So the people that we serve are behind Medicaid. So they have no other means. So they have no insurance, they have no health care, and they are able to contact us regardless of where they are in Texas. We're able to see them using telehealth platforms as well as technology to provide them the care they need. We do telehealth-based medication inductions, and we provide them with all of the costs of their pharmacy and all of the costs of their lab. We have medications that are mailed to them in their home. So imagine for someone in Alpine, Texas, who is able to get boarded addiction medicine care virtually, who does not need to go even to a pharmacy to get their labs, because we can do the lab, we can go do nasal swabs. We ship medications, including scheduled medications, to their home. And if they do need to be transported for some type of an assessment or a follow-up, we just partnered with Lyft Health, and Lyft will pick them up in a vehicle and take them to wherever they need to go, and that's statewide as well. So this virtual clinic has been providing care that would otherwise not be accessible anywhere in Texas. The other thing we do is we have what we think still is the only center for substance use training and telementoring in the United States at scale. This is several programs, and it's all designed to elevate the workforce in communities. This is more important in some ways than what we do with the virtual clinic, because this is the goal of putting ourselves out of business. Because what we want to see is how can we scale a workforce across a variety of areas for people who touch or interact with people who use substances, including public safety and EMS. How do we have them approach working with this particular population in the ways that are optimized for positive outcomes for the individual who's using substances? So that's the second piece of this. We've got 4 pillars. We've got our provider network pillar, our virtual clinic, and then we have the third leg in this stool, which is our Center for Substance Use Training and Telementoring. And then finally we have our research, and that's how that connects. So I've been part, as was mentioned, of the NIDA Clinical Trials Network since 2000. I was part of it at Harvard, and then when we moved down here, we're partnered with UT Southwestern, and we actually have a partner at UCLA. So the 3 of us work together to bring cutting-edge treatment research into our region. So we are doing a variety right now of work related to stimulant use disorder in particular, and these are all active trials that we're doing. We've embedded this in our clinic as well as community-based programs throughout. So this is the backbone of that NIH-funded work. The model that we're using is trying to shift the way we approach dealing with substance use disorder in the same way we might with other life-threatening diseases, like cancer. So when people come to our programs, we want them to know that part of the opportunity that they have is access to clinical trials, so that if the treatments that exist now aren't working, we're holding out the opportunity for them to be part of clinical trials as an alternative, or if those treatments would be preferable to the standard of care, we will do that as well. So why am I telling you all of that? It's nice. I'm very fortunate. I have a really amazing team. But the reason why I wanted to show it is sometimes I marvel at what has happened, because we've had so much growth. And I would say it goes back to the science and the training that we had and how we operate as an organization. When we did this, one of the things that we did is we committed this idea that we would only do evidence-based practices and that we would build a backbone of science into everything we do. So we have a data warehouse where we understand all of the activities that we do, we characterize everything, and that's the engine for what we do. It's based on the premise that health interventions with proven efficacy are rarely adopted in routine care. We've got this idea of voltage drop, right? And so the field, I'm sure people are familiar with the growing, we were just talking about implementation science. I am not an implementation scientist, but I am an admirer of their frameworks. And I also think that there's an energy that goes on in our field around how do we actually implement these programs that we know work and cross that chasm into implementation. So we have implementation scientists on our team. This is what guides the science that underlies what we're doing. So everything we do is based on a framework that may be familiar. I know I'm on a stage with a sign that says Translational Health Research Center. Our Clinical and Translational Science Award, we spend a lot of time looking at this. We set our work, and this framework is how I work to increase my funding, how to do my research, how to diversify my portfolio so we can continue to grow and sustain. So if you think about those clinical trial activities, somewhere here, these types of activities, and then the translational science piece of it, meaning how do we actually get it into practice in a way and understand how innovation is brought into the field. not doing. She's back. Is we do this work here, and then we've got implementation. And so this is an opportunity to move from more traditional biomedical life sciences we were talking about before into how we actually implement that. I'm so sorry, I really don't think I'm. If you can bear with me, I can bear with the screen, but it is going to go on and off, I think. Okay. Is really looking at how we can have impact. So this is the other place, and it's also the other place for interdisciplinary teams to work because we identify outcomes not just in the clinical space. That's a very conventional way of defining it. Did the patient do better? Did they respond? What is the outcome? What would be the outcome in a group or a population? It's understanding what the impact on the community is. How does that impact perceptions? Are there stigma reduction activities that go on as a result of providing this? We also look at the economic benefit, and then increasingly important, particularly in a state with respect that has some particular challenges. There are evidence-based practices in my field that I cannot deploy because they are illegal in the state of Texas. That means that we know that if we don't influence policy, we will continue to not be able to have the ability to deploy some of the resources. And these are not major evidence-based practices. Some of these are relatively minor and standard in most of the rest of the United States. So for example, a syringe services program. We know there's a preponderance of evidence that syringe services programs work. So our work is not just about the work of the science, it's about understanding how to communicate that in a way, not activism, but advocacy. So the connection to policy is incredibly important. We also know in Texas, if you don't, the fentanyl test strips, we're in the midst of an overdose crisis, and it is illegal to use fentanyl test strip to test a drug supply to ensure that it is free of fentanyl. And as a result of that, it increases the risk for people who inject drugs about being able to understand what they're using, and that can precipitate death. And Texas's numbers, if you're not familiar with it, are going in completely the wrong direction as it relates to fentanyl overdose. We relate to this very unfortunate party, but we are very much experiencing that now. And if you have children at home or people that you know or love that are using drugs, including anything that they may get, not just what they think is an opioid, they should be very, very careful because the fentanyl, the illicit drug supply in the state of Texas is poisoned, and the fentanyl will continue to be a real problem here. So, every single thing that I've shown you to date is anchored in a science framework. We have built hypotheses. We are not doing research because these are federal dollars. They are not research dollars, they are program dollars. But we have built into our evaluation a hypothesis in every project. So every provider network project, every recovery housing project, every program with recovery support, each of those has a research question and a hypothesis behind it, and a premise about how or not we're deploying the evidence-based practice, as well as the outcome of that evidence-based practice, which is why that database is so important. So I hope that sort of drives me to this idea that what we're trying to do is squeeze out of every dollar we get an opportunity that's 5 years down the road. What are we going to do with this? How are we going to make something happen that's more than what it is right now? And that's how you build other grants. So one example of that, I'm very proud of this, is an R24, and R24 at NIH, if you're not familiar with it, is an infrastructure grant. The only reason that we have this R24 and why I talk to people about diversifying their funding and really being creative with their funding streams, don't turn something down because it's not what you're used to. See if it fits your overall goal and your North Star, is because the reason that we have this peer recovery innovation network, it's like, $4 million, like $4 or $5 million over 5 years. This is the HEAL initiative out of NIH. The reason we have this is because of those state dollars. We would not have this grant were it not for the fact that we had jumped into this idea of helping the state solve a problem around deploying peer recovery support. Peer recovery support is people with lived experience trained to be able to support individuals in early recovery to live a better life. We would not have that had we not done this. And as a result of this, I have a postdoc and other graduate students are graduate students working on this project that is NIH funded and employed only because of that. And so this, again, is an example of something that goes from those pictures and those program things into actual funded specific aims that were reviewed at the National Institute of Health and funded as a result of that. And so that's a platform. So the way I like to think about it is this. I have a number of awards. We, my team of 94, have awards related to translational science. We also have the gift and the honor of serving the state of Texas by applying what we know about best practice and delivery of evidence-based practices for substance use to address a real public health problem. But if we thought about those as separate things, they would just be two separate things, and we'd be, yay, we've got some things. We got some other things, we got some money, my president likes our money, I was on a billboard, I'm pretty sure my president would never have put addiction on a billboard if we hadn't brought in $43 million. Our programs now are about 26% of the total sponsored programs at our university. But the thing that was interesting was how do you do more from one of this than just the individual component parts, and how you stack them together into a project. This is at the level of an individual, at the level of the center. It's whatever way it works for you in your program of work, in your sponsored programs or externally funded activities, and how you build them together to tell a story that's more. Each of these individual programs that's funded, unless they work with me, hasn't really connected all the dots to this, but this is our framework for how we're going to transform Texas and how we address substance use in Texas, how we address diabetes and obesity, how we address climate change, how we deal with other things. It's piecing them together with that big framework and understanding how each of these things plugs in and is interdigitated between these other things. And you can see this is more than just me. I started with me. It's my colleagues and us working together in these ways to work across this pipeline from preclinical to clinical. I pulled out the preclinical work from this, but we've got a bigger grid where we get to our basic sciences. And we've got other people now starting to be part of these, working towards these common goals. And then we've also built in the dissemination tools. We've got the Texas Substance Use Symposium. We started that in 2019 with 125 people showing up with about 3 weeks notice in San Antonio. I just checked our registration this morning, and we have over 600 people registered, 450 of them in person in San Antonio at the end of this month, coming together, which is now the largest substance use symposium. The reason I'm calling now that as an example is it's another opportunity for sustainment and diversification of our funding, because that is now the target of some major philanthropic gifts that we're looking for to be able to sustain this, because we made a decision, remember our North Star, that this would be a no-cost conference. Nobody should pay for this. Our community organizations have enough trouble paying their bills. They don't need another continuing education event that's not subsidized. We also made a decision not fully to be funded by the state because we wanted autonomy in terms of the content. And to not have, we wanted the editorial and content privileges to be able to do that. So that's one of our dissemination tools. And they're just, it's all layered, and I hope it's somewhat self-evident. There's other science going on here. This actually is, that should be an Article 42, pardon me. That's an STTR. And so that's another way that we're looking at that. And so we're looking at spin-offs of some of the innovations that we've developed with our publicly funded projects, looking at how we can commercialize some of the things that are so hard to develop in the academic sector so that we can be more nimble and agile and deliver at that. I didn't get into some of the technology work that we're doing because we just didn't have time. So I hope that as you're looking at that, you'll see that this starts to map to this, in my head it does, where we're mapping this translational science benefits model, but we're taking that and mapping that to our work. So I said the point of this, because I understood was about how you grow your own programs, is I am a liberal arts major who was an actor, who didn't know what she wanted to do when she grew up, who went back to school and lo and behold got a PhD in clinical psychology. I probably wouldn't even get in these days. Who had a North Star. And I knew what I wanted to do. And this has transformed my life. It's transformed my university. It's given me and forgive me, I'm not talking as a VPR now, I'm talking as a scientist and a faculty member, it's given me autonomy and power, quite honestly, at my university, because I've been able to coalesce around a platform and clearly communicate to my institution the value of the work that I do. Because the value of the work that I do is not just the value for me, it's not just the value for the people that we serve, but I'm doing this in a way that I think also communicates a value to my university. And that's how I wound up on the silly billboard talking about addiction. But I hope that that makes sense to you, because for me, this is one of the exciting things. I started by saying how much I love a university. I'm not a business person. I will never be an entrepreneur, but I feel like one in my academic environment, in service to my state, and in service to my country, and in service to my institution, and the people I care deeply about, who are people in recovery or people on their journey to recovery. So I'm going to do a shameless plug at the end. If you don't know about this, I saw a few posters. We have a preclinical, largely preclinical meeting called the BBC that's coming up March 25th and 26th. This is an NIH-funded R13 meeting around motivated behavior, particularly substance use disorders. And this is that Texas Substance Use Symposium that I was plugging. It's a really beautiful community-based meeting with a lot of different folks at the table talking about these issues and doing capacity building related to addiction and behavioral health. And I'll stop there, I think, because I'm about 30 minutes, I think. Thank you so much.
Thank you. I can't thank you enough. I looked at the picture of the full framework and how you're building capacity by connecting people whose work to themselves might seem completely disconnected from this picture, but that you see it, and that by putting this opportunity for them to situate an individual project within something larger, it's transforming university. So thank you for that. So we are going to take questions from the audience, and Shreek has joined Dr. Potter on stage, so I hope that you will ask lots of questions, because I have lots of them too. So we have, I think, microphone. Is microphone in the audience? Yeah. Oh, perfect. There's a microphone in each other. Thank you. Okay, so if you just raise your hand, and they can bring the mic to you, and that way you won't have to come down. Questions?
Terrified, everybody.
I'll start with a question. Dr. Potter, that was a really fascinating talk there about your transition from Harvard to Texas. So in the very beginning, you said something like, I had to pivot. And so tell us a little bit about that. You know, why did you feel you had to pivot? And when did you realize you had to pivot? And what were you afraid of?
Well, I'm always afraid. I think it's my baseline is that it probably is motivating from some of that flexibility that I talked about. The pivot that I think I was referring to at that point was when life is not just what you do at work, it's also what you have at home. And at that time, I think I mentioned I was a trailing spouse. So there was an opportunity, I don't know if anyone knows, this is me oversharing, which I tend to do. I don't know if anyone knows Lloyd Potter, but Lloyd Potter's the Texas State demographer. So Lloyd had a really extraordinary opportunity to move here and had worked with Steve Murdoch at Texas A&M. And it was at the time when Steve Murdoch went to run the census. And so how do you say no to your spouse, even though you're at the job that you absolutely adore, with a research family that you don't want to leave, with a job that's 5 minutes from your house in your dream home? So I did do that. And we went down here, and I had my K, and I arrived at an institution that had, one, there was no freestanding school of public health in San Antonio, and there was no social science really to speak of at UT San Antonio at the time, and I'm a social scientist. And so my pivot was about trying to figure out how to do my K, absent any mentors or sponsors that I needed to do that work, except those in Boston. And how was I going to make it at this new institution in a way that provided me security? What I was afraid of was, I think, what all of us are afraid of in some ways. I did not have opportunities to teach. I didn't quite honestly want to teach. I wanted to do research, and I wanted a job. And so how was I going to be able to maintain my career? I also think that, and I'll shut up with my long answer to this, but I also think I like being autonomous. I like being able to make decisions, and I learned that I had to control my funding to be able to be successful in the way that I wanted to be. And that was why I went into administration, and why I buffered myself with hard money for a while, and figured out what it was I wanted to do. Did that answer your question?
Absolutely, that's really a fascinating story and quite inspiring for somebody who wants to affect change in an institution that you have joined. So,
I like change a lot.
and autonomy, because that's one of the joys of academia. So there it is. More questions for Dr. Potter?
Hi, Dr. Porter. What an inspirational story. My question to you is, so we're all very fascinated by your story of your North Star. I think that gives us hope and inspiration to do these interdisciplinary type of work, and I think that's super important for our university here. I have a question, I guess, for both, for Dr. Shreek and yourself, is there are challenges when you're working across the silo, right? We like to be in our comfortable little disciplinary boundary sometimes, and then there are also this idea of how do you allocate resources where these sort of great inspirational type of places, centers can happen, like Translational Health Research Center. So I wanted to hear your perspective on that.
Sure. I think interdisciplinary work is about being really comfortable with ambiguity. I would also argue it's probably being comfortable with conflict. And a colleague who just retired from the VA said she was starting to practice radical candor, which when I first heard it, I thought, this is great. I can just tell everyone I don't agree with them, and I can just be very frank about it. But I think what she actually meant was not that. She's a much kinder person than I am. I think what she meant is we have to be comfortable having candid conversations. I also think you have to find colleagues as much as possible that share values, similar values. It's no fun to collaborate when you were written into a grant at 20% and then it turns out that NIH cut your funding and so the biostatistics is going, and you're down to 5% doing the same work that you were written in at 15%. So you need courtesy and collegiality and trust that. And then the last thing, and then I'll hand it over to you, is I think you also have to bravely, and this gets back to radical candor, be able to acknowledge when a relationship or a partnership isn't working and move on. And I say all that not because I do it particularly well, but I do think that we have to be honest with ourselves about that. And not every partnership or collaboration works. And then the last thing, sorry, that was the last thing. That's it for me.
So, thank you for the question. So, one of the joys of coming here to Texas State, and if I could borrow Dr. Potter's word, we already had many lodestars out here that have created an environment for collaboration and partnership. And this Translational Health showcase is one. And Melinda Villagran is one of those lodestars where the unique thing that she does is get funding from various agencies and gives it away to faculty across the institution and brings people together from very different areas to work together. Will all of these projects succeed? Maybe not. But I think many of them will succeed. And so what I learned coming to Texas State, and I kind of transitioned here with the Provost was very generous in letting me have like a part-time job for 6 months here while I was leaving my previous institution. And what I did in those 6 months is to really visit every lab, every department, every college, every research group to learn about Texas State. And that gave me the opportunity to be somewhat fearless in having conversations with people on how we can work across the boundaries. And that's really, and really Melinda's inspiration is how we have created our Office of Research Development, where you've seen in the last 6 months, we put out calls and we bring people from very different disciplines to work together, and we help develop these proposals. Your question was also on resource allocation. Here's how I look at resource allocation, and I think we have done that in our recent, allocation for our Run to R1, the $18 million that our president has generously provided to us for PhD students and postdocs. I believe in equity, but not necessarily complete equality. So we should have equity here when we do these things so that everybody gets an opportunity. It doesn't mean we're going to just divide by whatever the denominator is. And I think that's what we have done here. I know that is sometimes controversial, but I think we've done the right thing in the investments here as we have distributed our resources.
So as another VPR, I will just wholeheartedly endorse that. It's a difficult conversation to have, and we have to be clear about the equity piece. But I completely agree that at some point we have to really have some sense of the metrics and what we're going to invest in. I will also say I love resource allocation. I like allocating a lot of resources. I'm very comfortable with failure, but I want it to be demonstrable outcomes and that there's track records there or something that gives an indicator of success in holding people accountable. That was a great point. But I like to spend money. We have to spend money to make money.
Can I just ask a question? I was struck by the statewide approach that you're taking, and that's something that we're working toward in Translational Health Research Center with a state Center of Excellence on Health and Economic Resilience Research, so it's a strategic initiative. Last week I was in DC on a task force that's focused on information and health literacy, and Texas was one of the main topics because, as you know, we have 77 counties of our 254 that have no hospital. So 77 counties where many times they're stacked together such that Texans drive 2 hours or more to even see a healthcare provider, period. And many of these places don't have broadband. So I guess my question for you is, with this opportunity, if I'm going to have radical candor, I love our students. I love research with students. But our research has the ability to impact our state in much broader ways if we also think about how to take our research to places where it's really needed most. Do you have any advice for this group about how we could go about expanding our research to other parts of the state where it's really, really able to make an impact that's broader than just something that's right here?
Yeah, so may I ask a question though? When you mention the students, it's because there's a push and an enthusiasm around engaging students in the research activities? Is that what you meant? Sometimes? Okay.
Sometimes,
I just wanted to make
but
sure.
I think it's also just it's a matter of capacity. When we have teaching, research, and service loads that are very high, and so it's difficult sometimes to integrate those things. And so there's not an easy answer, but is there an easier way that you can think of to try to do research in places where it makes no sense to do it?
Yeah.
Make it more fundable, make it more impactful, etc.
Yeah, so I'm not the best person to talk about the challenges that are very much real on a general academic campus. The only thing, because I've always been in a health science center or in a medical field, the one thing I would say, we are dealing with a similar struggle with our clinicians. There is a dearth of clinician scientists in the United States because in academic health centers, there's a continued push for patient care. And it is driving these well-trained clinicians out of science. And it's really quite tragic. And we're all at the level of the world, I think, struggling with how to do this, but particularly in the United States and in Canada, I would say. So in terms of the work, I think that's why we have multiple missions. And it's probably the job of the person to the right of me to make sure that that's clear, because the work that I do could not exist in an environment where I was not free to do that, both in terms of the flexibility of my organization. I mean, when this dropped, nobody knew what to do with me, and I kept trying to explain it. No, this is really big. We're doing the whole state, and I still have that. But I now have, for example, I'll just give a concrete example, is if you get opportunities like that, first of all, I think you have to vision ideal state and then be very practical about how to fit it in. In my organization, what I finally started doing, because they couldn't go as fast as I needed them to, quite frankly, contracting. I mean, I work with community-based organizations that they have reserves of 2 weeks. If we don't pay them because someone messed up in accounting, they could lose their staff or go out, I mean, quite literally could go out of business because they can't make payroll. So what we did was we just embedded people. And again, remember, I had a lot of money to do this, but we embedded. So I think it's like 5 to 8 employees that I'd never see. They don't work with me. I'm paying for people in IRB. I pay for someone in accounting. I pay for someone or 2 people in purchasing. And when I say pay for them, they're a lovely person and they're an employee, but I've embedded them within the fabric of our system because I was stressing the system to an extent that it couldn't handle it. I have a colleague who really struggled with that because they felt like that was something that should come through F&A. I honestly didn't care. I just knew I needed to get it done because I had to survive with my work. And so I think that type of flexibility and that elasticity to solve the problem within the structure that you're walking into rather than let the structure drive you into what the ground or whatever it is. So, you know, as I think about teaching loads and things like that, I think that's why you have a VPR, is to advocate for the opportunities and how to solve that problem. I hope that answered your question.
So, yeah, absolutely. I think part of it is struggling with the internal, some of the things that you were talking about, you know, versus the real world where if you have a nonprofit organization that's 2 weeks, that might not fit the timeline that the university structures are set up to meet. But it's also the part about you have this gap with all of these partners, and that's daunting for someone who's a single investigator working on a single research project. And so somehow you took what you were doing at UT San Antonio and took it to the entire state. And so those were partnerships that you built yourself, or were they existing, or how did you do that?
They were everyone. So we built asset maps. We actually built it on a Salesforce backbone. So we went into Salesforce. We worked with a group that was, Salesforce is a customer relationship management software that the university probably has an account with because they use it for other reasons. And we built and custom built this CMS system specifically to identify it, and we characterized community assets. And then what we did was we used epidemiologists and demographers to help us understand, as well as state data, where there were gaps. And so we didn't do that all at once. We started with, you know, the very, very practical. It's not creative. It's just where were the low-hanging fruit? Where was the greatest urgency? And you know, some of the dots on that map have taken 3 years. We have something in Parma now. People in Parma, in that area, the Panhandle, you and I probably would not do what people in that region do to get their health care. At least for substance use, I can tell you that, because we had people that we found that were driving 2 hours a day to get a daily medication because of the way this healthcare system is structured. So that took a lot of time because we had to find the right agent there. So I don't know if that's, I would be happy to talk with you offline about that too, because doing that, you shouldn't have to reinvent that wheel. There are ways to do that, and there are people out there, and I think that we waste a lot of time trying to do things on our own. Back to collaboration that the colleague in the back there was mentioning. Sometimes we're so afraid of collaborating because we get really caught up in turf, and I finally have gotten to the point where it's just exhausting to worry about your turf. It's so much easier when we all go, yes, let's do this in an open way and figure out how we can work with each other.
So thankfully at Texas State we have no problems or delays with purchasing or contracting.
I'd like to move to this magical place.
I like your optimism. Melinda, we have 2 questions over here. Great, thanks.
You can
tell this is a performance space because I'm completely blinded.
Yeah, no, if they could turn down the sound.
I think it's just the theater space.
I just wanted to thank you for what you shared, and just as I have interpreted your background, I would call these passion projects for you, in terms of you really following your passion, and when you become passionate about doing this work, the opportunities come to you. I noticed that as well. Well, people will find you, and so it's great work that you're doing. We just want to commend you for doing that on top of your role as VP of Research as well. But my question is about sustainability. So working within communities. And so I was just looking at your maps that you shared and how you mentioned the diversity of projects that you have in terms of funding. Did you choose routes for commercialization to kind of help with sustainability as well, so you can help fund some of those other initiatives that may have been initially grant funded?
Yeah, so one of the things that was, it seems strange, but I was absolutely terrified, going back to things I'm regularly afraid of, to take this money, because I knew I immediately would have to be responsible for what to do next. You can't build, well, we do build programs like this and then cut their funding, but I didn't feel like I could be part of that. So the first month when I was deciding whether to say yes to the opportunity, it was about, I need everyone to know that my job is gonna be different. I'm not gonna be doing all that work now. My job now is 10 years from now. So right now I sit with 3 years more of that resource. But if it falls off a cliff at that point, I have done a disservice, a disservice to many people. I mean, obviously it's helped some people, but I have employees. I have programs that count on me. So my sustainability strategy started, I'm a clinical trialist, so retention starts at recruitment. So I approach this like a clinical trial and things like that. So everything I do is about the sustainability of the programs. And the good piece is that ARPA, some of this is on an ARPA backbone now. They talk about sustainability and require sustainability plans. So it was easy for me to talk about it with my institution, but this in a rough form is my sustainability plan. I'm gonna deliver the very best product I possibly can to the state, so that if there is funding that continues, they know that I'm a trusted source. I am not going to undermine or disenfranchise community-based organizations with my big, heavy-handed academic health center. I don't always do that well, because we are a big, heavy-handed academic health center. But we have to convey value to the community. We have to do a better job in the community than if they got that money directly from the state. And they are a partner in it. Because I was working for time, if you saw these slides the normal way I did them, most of it is the community groups that we work with. Those are 211 amazing community organizations. And I listen, and they have an open door. Again, I do fail regularly because this is a lot to move. I began working very intentionally, both by training myself in philanthropy and making sure that my institutional advancement saw me, and I don't mean me like I mean my program, because I work at a university where cancer, aging, Alzheimer's, addiction, that's, again, I cannot emphasize enough how stigmatized this type of disease is. It's not something people lean into hard. And I did, and so I wanted my program seen so that I could start to build relationships. So that's the other piece. The commercialization is more kind of fun and interesting. What I did though is I started a clinic. So that virtual clinic serves the state and has a good cause. We spread the money out as well and have other people extend our telehealth. But if everything retracts, the world in San Antonio has shifted just a little bit because we now have another addiction program. And by the way, I have the best addiction medicine doctors in the city. They are all boarded. We have the best therapists, and we invest $10,000 to $15,000 in each therapist to do evidence-based treatment. And that also generates revenue because we can take insurance and we can take self-pay. And so that was part of it. So again, this idea of diversifying is important. You gotta do more with scientists, we gotta do more with every dollar we have. Every dollar's gotta feel like $3, right? And so how do you do that? You do it with, I'm gonna get in front. I want you to see me. I'm not gonna wait to be invited to the table. And you do it hopefully with grace normally. But you know, the freedom that I have is that I'm a lot more pushy now. I wish my assistant professor self hadn't been quite so quiet. And some of us, I won't name specific subgroups, some of us probably are a little more polite than others, and I don't care anymore. You know, and people don't like me or they like me, but I feel like that's a freedom that I have. And the reason why I'm getting so personal about it is I wish that I have very few regrets, but I wish my academic younger self had known that. It doesn't mean you can be a jerk, but it's okay to ask. And I asked for money for my university too, so I'm expecting my university after all that F&A also to help me a little bit. But don't tell my president, because I haven't asked yet.
You want me to go ahead? Okay. Great. Hi, here we go. So I really appreciated your conversation on advocacy and thinking about policy, in particular for you as it comes to harm reduction and syringe exchange and all of those really important things that we need when it comes to addiction and recovery. For me, that looks like LGBTQ plus Texans work in health issues. And we know we're living in incredibly complicated times, nationally and particularly in the state. And so I'd love just to hear a little bit about what that advocacy has looked like for you and what it might look like for people that are assistant professors. And your role as a VP, that advocacy looks different than maybe for faculty or staff.
Yeah, well, the first, when I became the VPR, the first thing I did was, and we're continuing to do this, at our university as it relates to strategic planning, I'm required as part of the executive committee to have some goals that are shared across, and one of them was a DEI goal, excuse me. And so the first one that we did, and this year we're working on implementing it, was, in this particular case, it doesn't relate directly, but I think it's similar, was we had Women in Science. I see my role partly as elevating issues and speaking, because it is a reality that people earlier in their career may not feel that they are afforded the same psychological safety to be able to articulate those issues. So my job with tenure and a platform is to listen, seek my understanding, and then speak out. So I feel very fundamentally that that is an important part of my job, and I say that as a female scientist. So that's important to me. I think it is complicated, and do you do work in that? It sounds like, by the way, thank you for saying harm reduction. That was, you speak my love language. But in terms of LGBTQ, it's just so complicated in Texas right now. And so I do think it is about identifying the appropriate vehicles to do that. I like to think, and I don't know if I always do it, but I like to think that there are people, most people on my campus know that I am not someone that if you bring something to, it will not be addressed. It may not be addressed in the way that you want. I hope I'm answering your question a little bit. But it may not always, the outcome may not always be what we want, because there are complexities to how these issues are solved on campuses. But I want people to know that me and my colleagues, my other peer colleagues, are gonna address it and are gonna call it out, and that it's a safe way to do it, in addition to the formal channels that we all have. In terms specifically of advocacy, it's very complicated. I have an opportunity to meet with a senator right now in the Texas legislature. We're in legislative session, and I'm struggling about whether I'm going to choose to meet with that individual. And I don't want to do that because I think that problems need to be solved bipartisan, but I'm going to have to decide. I hope this isn't recorded. I'm going to have to decide how I handle that. Because there's a point when I don't know that I'm going to be effective in advocating if something I feel is fundamentally against what I know from a science perspective. I keep my legislative work. I can't lobby, right? We're state employees, so but I can be advisory. But if I'm asked to advise and I know that the impact could be weaponized or it could do more harm, then I won't do it.
Thank you.
We have refreshments, and I hope that this conversation will continue downstairs on the first floor. I would like to thank Dr. Potter and Shreek for taking your questions. I feel like this has just been a great model for us and gave us a lot to think about me personally, and I think hopefully you as well. And I hope that we will continue the conversation. But before we wrap up, I just wanted to thank our speakers.
It's not an Academy Award, but it is.
I proudly accept this award on behalf of my family.
Our Health Scholar Showcase Keynote Speaker Award, and I can't thank you enough for joining us.
Thank you so much, I appreciate it, and thank you for the invite.
Absolutely. Thank you.
Let's thank Dr. Villagran and her team for putting this on.
I'm a big fan of candy bacon, so just a little bit of that. Other than that, please go and enjoy yourself and continue talking and being downstairs as well. So thanks again for coming to our 7th annual